Right, good afternoon, everybody, and thank you very much. Assalamu alaikum for inviting me to this wonderful meeting. Thank you, Ahmed, for this great topic to talk about. I think he thought he'd get the dinosaur in the audience to speak about this. I have no disclosures to make. I've been asked to talk about the common femoral endarterectomy versus endovascular options for the common femoral artery. The older members of the audience will probably say this has long been a stent-free zone. Why are we talking about this? And why have people been very reluctant to be stenting or treating in this area? It's because we think stents are more likely to fracture. Whether that's true or not, we can debate. And once you've deployed a stent in the common femoral artery, it makes future attempts at access very difficult. So you only get one bite of the cherry. And common femoral endarterectomy is a very perfectly good operation. So why do we need to improve on it? I'm going to try to maintain some equipoise and look at both options fairly. So what is the evidence that the common femoral endarterectomy is a good operation? Well, there have been several reporters going back as early as 2010, where 𝗏𝗏𝗏 looked at about 117 cases. Admittedly, there was a retrospective series, but they had no deaths at 30 days. They had minor complications. The operation worked, the ABPIs improved, and they had very good primary patency rates. Most importantly, they have long-term follow-up data to 7 years. In France, Dufranc and others more recently reported on a series of 121 cases. They looked at an eversion endarterectomy technique, and they found very similar outcomes. In the United States, Nguyen and his colleagues data mined the ACS-NS-CIP database, and they managed to find 1,843 common femoral endarterectomies. What's interesting here is that when you look at real-life data, the mortality actually is higher than you would expect. 3.4% 30-day mortality is comparable to that of an open aortic aneurysm. So actually maybe it's not as safe or as small an operation as we think it is. And again, the wound problems that everybody's reported. Prospective registry data also consistently shows high success rates with relatively low complication rates and good primary patency rates. So highly favorable, sets a high standard, and makes it very difficult for the endovascular brigade to replicate. So what are we thinking? Well, those of you thinking, if it ain't broke, don't fix it, I think that's a reasonable state of affairs. But then others would argue that if that's how we acted, we'd still be going to work in a horse and cart, unlike the wonderful Porsche that some of you are driving to work every morning. So let's look at the endovascular data. There's some medium-term outcomes from a good number of procedures, 360 procedures, Bonvini and his colleagues in a retrospective analysis. They were doing balloon angioplasty, and that's an interesting thing. They were not stenting routinely, but they had a very high bailout stenting rate of about 37%. And I think that was one of the weaknesses. So the evidence there is if you are going to treat endovascularly, balloon angioplasty on its own is unlikely to be enough for most patients. So how about stenting routinely? Well, the TECO trial, again in France, concluded that if you were to stent primarily, the perioperative morbidity and mortality rate was significantly lower with stenting than it is for endovascular therapy. Well, that's not a surprise. That's the case for most endovascular versus open procedures. But the clinical and the hemodynamic changes at midterm outcomes were comparable. So this is suggesting that actually there may be something here. Shangal et al. In the US, in Ohio and others, wrote this very good article, a systematic review and meta-analysis. And they looked at the literature for routine stenting, selective stenting, which is the bailout stenting, versus endarterectomy. And they followed them up for a year or looked at 1 year outcome data. And they found that at 1 year, routine stenting was comparable to endarterectomy, both in primary patency and target lesion revascularization rates. However, endarterectomy was better than selective stenting at 1 year primary patency rates. And the findings they felt supported routine stenting as a management alternative to surgical endarterectomy, whereas probably not for selective stenting. And that answered this question: do you go to angioplasty and bail out stenting, or do you do primary stenting? And I think most of the evidence would suggest that a routine primary stenting is the way to go if you are going to go down the endovascular route. Well, what does the future hold? I suspect that directional atherectomy or balloon lithotripsy will even improve more these early results with an adjunct of a drug-coated balloon. And there is an ongoing randomized controlled trial now, the PESTO study, which we await the outcomes, the results of with interest. So having looked at all the registries and the evidence, the Society of Vascular Surgery, although quite old, 8 years old, their guidance are, at the moment, endarterectomy is probably the way to go, except in those patients who have a prohibitive risk of open surgery. And even the epidemiologist, 𝗪𝘂𝗃 et al. Did a review, which is always valuable, see how the epidemiologists see it, that probably endarterectomy remains the gold standard, but the long-term data of endovascular treatment at the moment is lacking, but should be forthcoming in the near future. So the answer to your question is, has endovascular treatment crossed the Rubicon yet into the femoral artery? I suspect probably not, but they're certainly on the banks of the Rubicon, and we will see more conflict in this area. And I thank you very much for your attention.